Okay, so we'll be getting into competency judgments today and how it glosses with Beauchamp and Childress's view, and we'll get into why Beauchamp and Childress don't think some competency judgments are correct in what they assess and how they assess the level of competency with level of risk. We'll get into surrogate decision making and the different views there. And this will be important to understand how autonomy glosses with other people deciding for you. But first, we'll start with competency. And remember, for Beauchamp and Childress, competency is task relative, and they're not talking about more general competencies, but it obviously has an important role in their view because you have to have some kind of competence to the task at hand. So what people who talk about competency in light of autonomy really want to do is that they want to determine cases where the patient is autonomous and we should solicit their decision and when we shouldn't. So when we should listen to them and when we should not listen to them in regards to their desire to have a certain treatment. So when medical practitioners determine someone's incompetent, they can override the person's decision and defer to surrogates or other third-party agents that would decide for them. So competency is not just a descriptive thing, it's a normative thing. And in philosophy, when we say these words, what we mean by descriptive is it's just about the facts and there's no judgment there. And by normative, we usually mean some kind of evaluative standard or gesture at something that is how something ought to be rather than just describe how they are. So empirical claims describe how the world is, and then normative claims describe how they ought to be. So with competency, while it is a medical term, there's some kind of evaluative framework that is there that's not just a descriptive medical fact. And this is why philosophy is important, because we excel at making these kinds of normative standards. So competency is not just a medical decision, it is a philosophical stance. So your normative judgments should determine the competent and the incompetent. If it doesn't do that, it's not really doing what we want it to do in the medical case. So the definition of competence, of what we're really trying to get at, and the criterion and tests for competence have to be distinguished here, and we'll see that Beauchamp and Childress also make this quibble about some competency standards. So the definition fills out the meaning of like what we're talking about, and it's getting at some ability to perform a task that applies in more general situations. That's what we're trying to get at, but our tests don't always do that. Sometimes they're inaccurate. But on the definitional side, the criterion is supposed to give us the necessary and sufficient conditions for satisfying the definition. And for Beauchamp and Childress, it's task relative. So if you people are globally incompetent, you might be able to explain to people who are generally incompetent what a dental procedure requires and what it will mean to them in a way that they can give informed consent. So these competencies, like we talked about last time, might vary over time. They can have changes by chronic intellectual problems or memory. They can be temporary or long-term. So this concept of competency, why it relates to autonomy. So the characteristics of the competent person are also those of the autonomous person. So the patients or subjects are competent to make a decision that would be considered autonomous if they have the capacity. And what we mean by autonomous and have the capacity is one, to understand the material information for the procedure. Remember, not all of the information, just the relevant information. 2, they have to be able to make a judgment about the information in light of their values. So if they can't understand how a procedure fits with their worldview, they can't, then they're not reasoning properly. They need to also intend a certain outcome of the procedure for themselves. And they also have to be pretty freely unrestrained to convey their wishes and desires to caregivers and doctors. So if you're going into the medical field, this is relevant because if you are wondering why we think that patients need autonomy, is a lot of the times these decisions to do a treatment or not are not a medical decision. They're a normative decision on the side of the patient. There's nothing in medicine that tells you whether or not the patient thinks the risks are worth the benefits are worth the risks. So when they make a medical judgment, this is entirely a personal decision. That's not to say that it's arbitrary, but that it uses the patient's values to understand how they want to proceed. So this is why doctors can't just make the decision for patients. A lot of people make this argument in bioethics that medical judgments are normative judgments, not medical descriptive judgments. So this is why we think that autonomy oftentimes get at the best interest of the patient, because they're in a position to know better than the doctor what their interests are. So competency is going to come in level of degrees, but it's not really helpful to speak of degrees because competency sort of requires a binary decision, yes or no. In the medical field, we can't really make use of a spectrum so well because it's not clear how that spectrum relates to the kinds of decisions that patients need to make. One view that actually does defend something like this is Buchanan and Brock's view. So they think that there's a sliding scale relationship, which means that it's not a binary yes or no. But as the risk increases for a procedure, there requires more competency. And they have a book called Deciding for Others, The Ethics of Surrogate Decision Making, if you want to check that out. But essentially, this is their view, and this is what Beauchamp and Childress criticize. But first, we'll talk about what the view is. So we have on the y-axis the danger of the procedure. So this is the risk. As the risk goes up, the y-axis gets higher. And then we have patient competency on the x-axis. So this 45-degree angle line here is going to be the line where both the patient competence and the danger procedure risk is increasing equivalently at a 1-to-1 ratio. And the view is something like this. It's that when the patient is only minimally conscious, you can't consent to really dangerous procedures. But if the patient is just minimally competent but consenting to a fairly risk-free procedure, they can consent. And this space is like the total possible space of risk and patient competency. So what can you consent to? You can consent to things that are at a risk level comparable to your competency. And that's represented by this line. So anything above it, not consentable. Anything below it is consentable. So as you become more competent, you become more able to consent to more risky procedures. So here's the consentable and the non-consentable here. So Beauchamp and Childress kind of detect what they take to be a confusion in this sliding scale discussion, because they don't think the degree of competence, they think the degree of competence is being confused with the degree of certainty about someone's competence. So what does this mean? So this means something like they are confusing the test for the actual judgment of the test for the actual concept of competence. So there's ways that we can assess people for their competence. We've already said this. What Beauchamp and Childress think is that Buchanan and Brock are really talking about tests for confidence. So as the risks to the procedure increase, we need to be more certain about the confidence of the patient. The patient doesn't have to have more confidence. The tests just need to have more certainty. So if we redraw this line, it's going to be, this is the original one, we have the risk or danger, and then we have the patient competency. If we redraw it in line with Beauchamp and Childress' preferred view, we have something like this, where the danger of the procedure is still on the y-axis, but the evidence of patient competency is on the x-axis. So, for example, something like a very minimally risky dental procedure, you could rely on something like simple questions or just how the patient presents. If the patient seems at least minimally competent, knows what day of the week it is, they can hold a conversation. That is enough consent for a very minimally invasive dental cleaning. But as you get to more risky procedures, you need higher levels of evidence for the patient's competency. So if you're doing heart surgery, you need to really be sure that the patient is competent and not making a misinformed decision, and that they're actually competent. So this is a way to save mostly what Buchanan and Brock are saying, but to avoid confusing the evidence with the actual competency of the patient. So since the kind of tragedies of the World War II experimentation and concentration camps, we've kind of come to the consensus that informed consent is the only way to go. But this term informed dissent didn't come around until the 1970s. But now most codes are really emphasizing that physicians and researchers must obtain informed consent. If you're ever reviewing or submitting a research proposal for the IRB, the Institutional Review Board, you'll come to understand how rigorous this could be, or tedious, in making sure that the patients have all the relevant information and that you're not leaving anything out. So the biggest expansion of informed consent was along the lines of 4 here, which is to say that disclosure of information has been a big area of expansion, where there's more and more information that physicians have to provide you to think that you are informed adequately for consent. And informed consent can be thought of as autonomy applied to decision making in the realm of medicine. So this is why we're talking about autonomy first in the last lecture, and we're talking about informed consent here, because autonomy is kind of applied in a certain situation to get informed consent. So there's several elements of informed consent for Beauchamp and Childress. So there's a certain kind of threshold of competence or ability to understand and decide in certain scenarios. You have to be voluntary in deciding. This is kind of like free of coercion, or at least free of a sufficient level of coercion. And then there's these other elements, which are information elements. You have to be disclosed the material information. You have to know what the relevant plan is. So it's just not the treatment itself. It's like everything, the big picture medical plan of what you're going to be doing. So you also have to understand. You can't just have access to information. You need to actually understand 3 and 4 here. That's the 5th criteria. And then the last elements are the consent elements. So you have to actually make a decision in favor of the plan proposed. And then you have to actually authorize, which decision and authorization is different. So decision is, I want to go through this plan, and then authorization is right before you're going through with it, is you're authorizing the authority of the people to go through it with it on a certain time, day, etc. So Beauchamp and Childress give us what informed refusal will be. So there's a difference between refusal and informed refusal. So the difference here would be, this is informed consent. This is what informed consent requires. What does informed refusal require? Which means if you have a condition, in order to be said that you are informed and refusing the treatment, you need to have 1 to 5 here. And the only difference is going to be the 6 and 7. And at that point, the rejection of the decision at odds with the plan and then refusing the authorization for the plan is going to be what makes this an informed refusal. So it's not enough to say that you just refuse a treatment because we don't know if you're competent, we don't know if you're voluntary, we don't know if you have the relevant information, we don't know if you understand the disclosure of the material and the recommendation of the plan. So to be an informed refusal, which is to say, if a patient's refusing a particularly critical treatment, you probably pressured to have informed refusal, because if you didn't explain what might happen if you didn't provide them with the treatment, you might be liable to legal action. So a way to allow a patient autonomy with this seeming tension with beneficence, so it seems like the patient should go through with it. How do we make sure that they're not making the wrong decision? Well, we inform them of everything. We make sure that they can understand all the information. And then for the consent elements, it's just they're refusing, so they're consenting to not going through the medical treatment. So some people have argued that disclosure is really all you have to do, and all of the other parts that we talked about of making sure that they're competent and understanding is not so important. But from a moral standpoint, this is, what they're pointing out is a more legal standpoint of like, if you give people access to the information, you can't ensure that they're competent, and that might make you free from legal action. But from a moral standpoint, the informed consent angle has less to do with liability and more to do with how can we make patients autonomous and make an autonomous informed decision. Another article or another academic that Beauchamp and Childress disagree with is Jay Katz. He's another famous bioethicist. Was a psychiatrist, but he critiqued a lot of medicine's disregard of informed consent early on, so he's pretty important for making autonomy be a goal. And but he understands informed consent as more of a collective decision making between the doctor and the patient than Beauchamp and Childress do. Beauchamp and Childress are more on the side of the patient's autonomy in being an individual decision maker, while Jay Katz is more of a shared decision-making process guy, where you can reason together and your goal is to reach a consensus on the patient's best interests. So while Beauchamp and Childress share the critique of the past practices, they don't share his positive account of this shared decision-making. So importantly, they want to distinguish exchanges of listening procedures from acts of authorizing them. So while shared decision-making is a worthy ideal, it doesn't really define what informed consent is, or displace the idea. So it doesn't replace it, and it doesn't capture it. So what the criticism is basically, just because the shared decision-making procedure might get eventually having the patient be informed and making a decision, just because that's how it came about doesn't mean that it's actually capturing what we care about in this situation. So some standards of disclosure. These are important for what kind of standard of disclosure for information, what theories are out there, and what they require to disclose. So the professional practice standard is kind of the most minimal account, or potentially the most minimal account. And it's something like the medical community is supposed to determine what is relevant for the patient, and that's basically it. The problems with this particular standard are few, and uh, the main one is that there's bad customs and negligence and bad practices in the physician community that would not provide all the information for the patients. So it can't eliminate the possibility that the physicians aren't actually giving all the relevant information. So this standard, the worst problem with it is that it doesn't really speak about patient autonomy. So the professional standards are guidelines for medical judgments, but decisions for or against medical care are non-medical decisions. We've already talked about this a little bit. And that has to do with the options and the values of the patient. So there's this very big gap here between what the doctor believes to be relevant for the patient and then the values of the patient. And the professional standard doesn't really ensure that there's any information that the patient really finds relevant to make their decision. It's just what the doctors think is relevant for decision making. But the overall nice thing about this standard is that it lets the doctors and physicians decide in a way that could be pretty consistent, although miss some features that are particularly important for autonomy. But it's kind of the easiest to do because you kind of just let the physicians figure out what's relevant, and they may not get that right. The reasonable person standard. The standard shows up in court cases all the time, and it's big in the US. It's something like, it's a kind of a theoretical question. What would a reasonable person want to know in the case of this procedure? And if the doctors didn't provide that, then they plausibly didn't disclose enough information, and that could invalidate the informed consent. So the obvious problem is it's not clear what a reasonable person or a reasonable physician would suppose in any given standard. So this might do better in the idea that you might be able to get at what a generally reasonable person would want to know, but in specific cases, it begins to become pretty hard to actually apply. What would a heart doctor think he needs to disclose to this particular patient? That begins to not be very easy to answer. Maybe you can just decide it intuitively, but it's hard to fill out before you know the specifics. And even once you do, it becomes very intuitive and not particularly principled. The subjective standard. This is going to determine adequate disclosure by reference to a specific informational needs of the patient, rather than a hypothetical theoretical person. It is relying on what a particular person would want to know. So if I was evaluating whether or not you had informed consent, I would assess what your values are and what you actually think are reasonable, and whether or not the doctor figured out what you think is a good standard, is a relevant piece of information for you to know. So Beauchamp and Childress like this standard the most, but it's not very useful for the law, since doctors can't be expected to do an exhaustive background check. So the flaw of this is that it's particularly time hungry in a world where doctors don't have that much time with patients. Figuring out all of the patient's preferences and values and desires would be burden to the medical institution. So while this is the morally best standard, it's a bit hard to actually apply for practical reasons. But it's at least clear in that you could apply it theoretically to any particular person. So that's one benefit to it. So talked about cases of intentional non-disclosure when a doctor does not disclose certain informations in the case of emergency, incompetence. These aren't controversial, so when you need to have an emergency procedure, if the doctor doesn't disclose everything and they just go through the procedure, not a particularly controversial way to go about informed consent. Just say, look, we're pretty sure the patient wants to do this. We don't have to disclose everything because we're under a time crunch. We have 5 minutes or the patient's going to die. In that case, this intentional non-disclosure is not controversial, but we might wonder what is controversial, and this is like the therapeutic privilege, which is like doctors withhold information because they think that it might be bad for the patient to know. It might be mentally or physically actually bad for the patient. And this is more controversial. Not a lot of people agree with this. But this also links up to placebos and whether or not incomplete disclosure or even intentional deception can be permitted. So if you're in a randomized control trial, you might wonder whether or not you can consent to potentially not actually getting the medication that is used in the study. You might get a placebo. So if there's a 50-50 chance you get a placebo or a actual therapeutic, can you consent to a research trial that actually does that? Most people agree that you can, but something interesting for the discussion post might be to interrogate that more, because if you don't know if you got the treatment or not, you might think that that is relevant information that is critical for informed consent. But you'd actually have to give reasons why that is somehow better than consenting to under normal clinical trials where perhaps everybody gets the drug. You don't know if you're going to actually have the effect that the drug is proposed to have. So that might prove too much and might undermine consent in any clinical trial, which would be plausibly bad. So some of the most popular arguments against deceptive non-disclosure is that it might undermine physician-patient trust, and especially that's important today in cases of misinformation and lack of trust in government and medical institutions in the US. So this is just to say that these kinds of intentional deception, where you leave out information, is controversial. And if you want to explore this for discussion post, maybe walk through some of these cases here where doctors leave out information that might cause some kind of reaction in the patient, either mental or physical, and whether or not the doctor is able to leave that out while still respecting patient autonomy, or if it requires suspension of autonomy and if that's justified or not. So some defenses of placebo stress that consent to an unspecific generic treatment, such as an effective medicine. An appeal may also be made to the patient's prior general consent to the goals of treatment. So going into the clinical trial, you might say that the patient doesn't need to know the information about whether or not they're in a randomized controlled trial and receiving a placebo, because they consent to the general process of medical discovery, which is to try new things out. Sometimes they don't work. And one of the ways that you know things don't work is you have control groups that don't get the treatment or get the standard of treatment rather than the new drug proposed. So this is one way that will kind of try to save autonomy in the case of randomized control trials with placebos. So consent can bog down medical research, especially in cases of like epidemiological research. COVID was a good case where it seems like if we had access to information that patients had that would make change the way that we approach COVID, then if we're not able to get that information because we have to have them consent to it, or it would be particularly burdensome or add to wait times, we can clearly just not have patients consent to collecting their information. Maybe you don't think that. Maybe you're a bit more of a libertarian. I would like to hear some thoughts there. If you do feel like that, that public health can't limit these cases, or if there's a way to save autonomy with some kind of opt-out, opt-in system, and have both the public health concerns and the respect for autonomy. So there's a lot to the understanding point, and we'll just run through it fairly quickly. So some people argue that patients can't comprehend enough information and they can't appreciate the relevance to make medical decisions. And such claims are usually pretty overgeneralized, but and they have like an over-idealized sense of full disclosure, which would just be too burdensome and includes information that's not relevant. You can simplify the way that you convey risks, so it doesn't seem like understanding requires you to be an expert on probability theory. But the one really dangerous aspect is that there's the therapeutic misconception, and that is when you don't understand that clinical research is not usually intended to improve the patient outcome. It's supposed to figure out whether or not a drug is effective or not. And this is related to therapeutic optimism, which is that you understand the probabilities, but you're optimistic about the outcome. So you know that it's unlikely, but you're very optimistic and think that you will benefit from the drug in question. And lastly, one problem to understanding with the status quo of giving a lot of information to patients is that inundation with information might be a problem at some point. If you ever had a medical procedure, you'll know that they'll give you packets upon packets of information. You probably didn't read any of it, which is a problem for informed consent, obviously, because if you're not even using the information that the doctors find relevant, you probably don't know all the relevant information. Voluntariness. Beauchamp and Childress use voluntary in a narrow form, so it's not synonymous with autonomy. They define it as a willing an action without being under the control of another's influence, and this is like a sufficient level of influence because everyone's influenced at the end of the day. So not all influences are controlling. That is to say, a problem. But if you are being coerced or bribed, that would probably be something that contradicts the voluntariness criterion. So they consider a couple forms of influence: coercion, persuasion, and manipulation. So coercion is only going to occur if the person intentionally uses a credible or severe threat to control another. Persuasion involves having a person to come to believe something through the power of reason. And manipulation is kind of this generic term for several forms of influence that are neither persuasive or coercive. So, example of manipulation would be like monetary offers or rewards. So persuasion is not really that controversial because it seems to be the case that you're enhancing the patient's autonomy. And the coercion occurs and is suspect when it is undue. So lastly, we'll talk about surrogate decision making. So this is supposed to be when decision makers are authorized to make decisions for doubtfully autonomous or non-autonomous patients. And this is important because surrogate decision making occurs every day. People withdraw treatment for their loved ones every day. or make decisions for them because they're temporarily or permanently incompetent. And the worry is that the surrogate will rely more on their values and judgments rather than what the patient would want. So there's a couple standards here. There's the substituted judgment standard, the pure autonomy standard, and the patient's best interest standard. And we'll run through these fairly quickly. So the substituted judgment involves a surrogate to try to decide as the patient would if they were competent. So it's something like in cases where they have deep familiarity with the patient and their values, they could make a judgment that the patient themselves would come to. So knowing something about their general features, their age, their religion, usually not adequate to actually make this judgment. You would usually think of this in terms of like a family member who knows the person very well and could make a judgment that is in line with the patient's own values. So something interesting to think over is that Beauchamp and Childress think that it makes little sense to actually use substitute judgment standard for a patient who has never been competent. So think of someone who has some kind of mental incapacity to make a autonomous decision. In that case, if you never knew what a patient would choose autonomously because they never were autonomous, then there's no standard for actually making this decision. So you can't use the substitute judgment in the case of a patient who has never been autonomous. You have to use some other kind of standard. And maybe something you would wonder is whether or not this makes sense or not in a discussion post. So the pure autonomy is this sometimes referred as precedent autonomy, and this is when you have a clear statement of DNR or some other kind of document where the patient is explicitly saying their wishes, and if you were making a judgment for them in light of their past decisions, this would be a pure autonomy or precedent standard. So remember, we're trying to figure out how to preserve autonomy on the one hand when a patient is not competent by reasoning through third parties. So the last way to do this, which probably gives up the most ground in terms of autonomy, is the best interest standard. So when you don't know what the autonomous preferences of the patient are, the best interest standard is the one you should use. So the surrogate, so say a person just shows up to the hospital, don't have any information about them. The doctor has to make a decision about whether to treat them or not. What the doctor should do on this account is to just judge what the medically best benefit to cost ratio is, and then do that. If it's treatment, do that. If it's not treatment, do that. So this is just a quality of life judgment. This is not what the patient, we have no idea of knowing whether or not this is what the patient wanted. And this is just trying to do the medically best thing for the patient without knowing any prior details about the patient.